Hello, everyone, and welcome to Bring Patient Brain Talks. This is a special edition we are bringing to you because today, earlier, just a few hours ago, the FDA approved the Alzheimer's drug Aducanumab. It's a conditional approval, but since it's been such a rocky ride to get to this point, we thought we would delve into what this approval means and where we're at today. So I'm very pleased to have with us two doctors, Dr. Stephen Salloway. He's a principal investigator of Aducanumab, running a clinical 3 trial of the drug, and also director of Butler's Hospital's Memory and Aging Program. And also Dr. Lon Schneider. He's the director of the California Alzheimer's Disease Center at USC, and he was also a site investigator of Aducanumab. So gentlemen, welcome to both of you, and thank you so much for joining us.
Thanks for having us.
Okay, I want to start first just pulling apart what this really means, because there's been a lot of anxiety over this decision, whether you were for or against it. And when you read the FDA's statement of approval, it says it's a conditional approval. So can we just dive into that a little bit and talk about what exactly, and this is to either one of you to jump into, what does the conditional approval mean?
Steve?
Do you want to take that, Dr. Salloway?
Did you see the language conditional approval? I saw, well, I'll just start in and Lon can add it. And I think we'll probably have different views about the significance of the division.
That's later.
This was an accelerated approval pathway that the FDA used. And they did impose a condition that an additional trial, a placebo-controlled trial, would be conducted to try to replicate the positive results seen in one of the trials. And further action could be taken based on the results of that trial. So
are you saying then that's a normal process for this type of approval?
It wasn't approval for use, but with the stipulation that an additional trial be performed and that trial corroborate with one of the 2 trials, the positive trial seen in the submission.
Yeah, exactly. Deborah, I would not use the term conditional. Actually, the FDA doesn't have a conditional approval. This is accelerated, and it's accelerated on a number of reasons that we could talk about later. And there's an amendment to it, as Dr. Salloway said, that during this period of time that we're using it, the sponsor has to do a study to try to confirm clinical effectiveness, clinical benefit.
Okay, so let's talk a little bit about the drug. I mean, it's the first one really that is aiming for a hallmark beta amyloid plaque. And I know both of you were involved in the trial, in the investigation of the trial. So I'm going to start with Dr. Schneider because I want to hear your experience and what your opinion is of this drug and whether you feel like it's ready to be FDA approved.
So actually, the FDA approval for this drug was a first in Alzheimer's disease, because the basis of approval was on the antibody's ability to decrease plaque. That's the basis, not that it was effective in the studies, but that it could decrease plaque. And then the rest of that was, and we believe that the decrease in plaque would establish a reasonable potential that clinical benefit could be shown. And this is a bit unusual to approve a drug on a biomarker it's not been done in dementia or Alzheimer's or most of neurology or psychiatry. It is done in cancer, where we'll use biomarkers that can predict, for instance, outcome to a greater or lesser extent. For instance, the size of a tumor. In some cancers, the reduction in the size of a tumor can predict survival, but not in this area. So this is new.
So is it a good thing? Is this, I mean, some people are declaring this is just like a new, I mean, we are now on to a new stage of Alzheimer's drug discovery. Would you declare that and say, I mean, before we really only had medications to treat symptoms of Alzheimer's, but this is actually targeting the disease pathology. Is this as great as some people think it is, in your opinion?
Well, I think it's, and we spoke about this recently, Deborah. I think this is a turning point in Alzheimer's research, and I'm hoping this will open the door to a new treatment era for Alzheimer's, where we have to do biomarker testing to confirm Alzheimer's disease. And hopefully we have this treatment and others that will follow, that we can build on, that modify the underlying pathology and hopefully slow the course of the disease. I mean, Lon is right. There's still much more work that needs to be done with this approach. And also, I think the Alzheimer's field really needs to, there's no time to waste. This is just the beginning. And this will pose challenges, but I think overall, this is clearly something very positive for Alzheimer's patients and families, and for the future of future research.
And I mean, those challenges aren't small ones. I mean, let's face it. I mean, it's hard to find that you have beta amyloid plaque in your brain. I mean, a lot of people who know that are in clinical trials. It's not something you can go to your doctor and say, scan my brain and tell me if there's plaque in my brain. So
there's two pieces to that, and I don't want to hog the time, but one urgent need right now is to validate promising blood tests that can predict amyloid plaque and the buildup of tau tangles, another important protein in Alzheimer's. We have blood tests that are looking really good, but there just aren't going to be enough PET scans or it's not going to be accessible or practical to do lots of spinal taps here in the United States. So we need to get really urgently move that forward. The second issue you bring up is about learning about your risk. And I think it's less of an issue once you already have cognitive impairment, because something is wrong, causing you to have memory difficulty, and Alzheimer's may be the reason. And so finding out, hopefully it gives you new options for how to manage your life, but also how to treat it. I think what's going to be even a bigger issue in the future, and it's already here, is finding out about your risk before there's any memory loss. And this is where the blood tests and PET scans and genetic tests and so many others will come in. That's a very individual decision. Some people are very eager to know and be proactive. Some people are really frightened and don't want to even consider.
What you bring up is a really difficult situation for doctors. Dr. Schneider, I'd like your opinion on this. Like, what are doctors supposed to tell patients at this stage in the game? I mean, it's a new drug. It's not very accessible. You don't have the tools to really diagnose plaque unless people want to pay out of pocket, of course, or they're involved in a clinical trial. So as a doctor, what does this mean? How do you redefine this space, and what do you tell patients?
Well, we have been talking about this just now. This is a double-edged sword. And by approving the medication on the basis of a change in the biomarker, the FDA has essentially elevated that biomarker, the amyloid in general, to a premier place, to a major place, where, just as Dr. Salloway described, we have these various tests to see if somebody's amyloid is statistically higher. But people older people in their 70s, for example, can be perfectly cognitively normal and have elevated amyloid. That then becomes a statistical risk that they are more likely to develop cognitive impairment than their twin who does not, but not that much more likely over the next several years. So then what do? We have a drug that's approved to decrease that biomarker, those plaques, and we have a good amount of uncertainty about ultimate benefits. And that comes back to the uncertainty of the approval indication. Steve, I'm sure.
I don't really view it as a double-edged sword. Well, first of all, I want to give a big shout out to Lon. I mean, we've been warriors in the Alzheimer world for for decades. And, you know, this is one of many compounds that we tested and many other trials that we participated in together. So even though we may disagree in our perspective, we've been united in fighting Alzheimer's for many years. Yeah, I think I see it as an advance. I see that having this treatment, and I understand Lon's points and they're well taken, it will make these tests more readily available and hopefully covered. So there will be spinal fluid testing. Hopefully, I'm hopeful that there'll be PET scan. Amyloid PET scans will be covered as well. So what was not available will now become available. And so we can make a much more, and I feel I'm a pretty good clinician. I've been at this for a long time. But some people, I can't tell if they have amyloid plaques, and some things look like Alzheimer's, but they aren't. And so having this test available is really going to help, and especially doctors with less experience, it's going to help over time. So this will make these tests available. I think we need to go, the next step is develop the blood tests, because the PET scans and the spinal taps just aren't practical for a large number of people, and they're too expensive. And so we got to do better. And I think we're on the verge of that. And I think this approval, this is sort of tangential to this approval, but I think this will accelerate that. And I'm really excited about that. People want to know. Yeah. People that I encounter, I mean, the people that don't want to know don't come to see me. Well, I don't know about Lon, but the people that do, they really want to know. They want to know about their risk. They understand, just as Lon said, it doesn't mean if you have amyloid plaques building up above a certain level that you're definitely going to have memory loss. We need to get a much better understanding of the time course and the prognostic factors. And I think we can do that. You know, it's going to take time, but.
So I want to hear, Dr. Schneider, do you feel that people, your patients, they want to know most of the time whether they have plaque in their brains, if they're experiencing memory loss?
If patients have various levels of sophistication and also involvement in their various illnesses. So many, if not most, don't actually come to us asking, hey, I want to know about plaques and amyloid in my brain. They come with some specific memory complaints. Now, Dr. Salloway and I, though, actually might share a rather common practice, and that is that many of our patients at a university setting are other physicians, other highly educated people, and they do come to us with important questions and insightful commentary. But Dr. Salloway and I would agree that biomarkers are an advance. Biomarkers are here for diagnosis or for diagnostic support. So we do amyloid PET scans. We do lumbar punctures to measure amyloid and tau. And we actually do blood tests to get the probability, to estimate the probability that someone has amyloid plaques. And we will discuss that with the patient. Here, though, today, what we're talking about is the linking of that with a drug, and with a drug that is designed, that is approved and designed to lower amyloid plaques.
I mean, there's still a lot of debate in the Alzheimer's research sector as to whether or not the plaques are the right targets, right? I mean, let's face it. I mean, there's a divided camp there. I mean, we know through longevity studies that there are people who have plaque in their brains and never get Alzheimer's. So how do we address this question?
Well, amyloid plaques are a core pathology a core component of Alzheimer's disease. I don't think there's any debate about that. But Alzheimer's is a complex disease. I mean, there are other proteins that build up. Nerve cells basically degenerate. Synapses break. Connections between nerve cells break down. That's what causes the dementia of Alzheimer's. And so there are many factors that go into that. I think amyloid is a reasonable target, especially early in the disease. I think later in the disease, there's no real evidence to support that lowering it has benefit. We're trying to see now, and Lon's very involved with this program as well, in prevention trials for people who are cognitively normal building up amyloid, whether removing it will delay the memory loss. We're hopeful it will. We have to prove that. So I think amyloid is definitely a good target, but it's certainly not a singular target, an isolated target. I mean, this Alzheimer's is going to require a combination treatment. I'm very hopeful about the future. This is so exciting to me. I'm very hopeful about the future because we need to tease out all the things we're talking about. This link between amyloid and cognitive decline, what the other factors are, how to create a prognostic, develop a prognostic information. So people, increasingly in my experience, people want to know about their risk and they want something to do about it. And it's our job to put this together for them. And they're willing to step forward, and we really need to make the most out of it.
Do you agree, Dr. Schneider, that there's enough evidence to actually I mean, you know, this drug has been on again, off again with its long history now of almost 2 years of people on trials, taken off on trials, put back on trials, given a different dosage, you know, now we're at approval. Do you believe, and there's been a lot of debate around whether or not there's enough data for the efficacy of Aducanumab. Do you believe that there is enough data to actually bring this drug to market in early stage Alzheimer's or people experiencing MCI?
So first, just want to expand on what Dr. Salloway said. We are working on biomarkers. We will understand, and we continue to make progress to understand how we can use the biomarkers, how to diagnose early, to predict course of illness, to see how one may interact with the other. For instance, a fairly prevalent hypothesis, which means a guess, but an educated hypothesis that we collectively have is that perhaps decreasing amyloid creates a lag effect, and that somewhere as a result of decreasing amyloid, we're able to decrease tau, the abnormal tau protein that might be more involved with memory. This is possible, but this is a guess, this is a hypothesis. So then back to the treating and whether this drug, in my opinion, whether FDA should have approved this, is that the studies were set up here to try to determine whether there would be cognitive improvement, memory improvement when we use the antibody. And what was found is that the two studies were first stopped for futility, and then any evidence of cognitive improvement is not well supported. There's no doubt this reduces plaque in just the way we think we want it. So yes, so because there's not a demonstration of cognitive improvement, I think approving this for marketing was too soon.
So what comes next then? I mean, you bring up a lot of great points around where, if it's gonna take care of the plaque in our brain, but not really help our memory, then, there's a lot more research that has to be done.
I'm gonna say one thing, we don't know whether it will help memory
Right.
over the long term.
Right.
Go ahead, Steve.
We're unclear about that, but that's a big point. I mean, if you're going to take a drug, you're going to hope that things improve, or at least they don't get any worse.
This is Deborah, this is we've been over, this is a controversial data set. As you said, the trial was interrupted. We made a dose change right in the middle for the ApoE4 carriers, which was 2/3 of the trial population. So a lot of them didn't get to the top dose. Dose matters. They did a futility analysis and they stopped the study early. The data set's incomplete, on and on. There are numerous issues with the data. So Lon and I don't disagree about that. But how do we interpret what the data in totality represents? And I think we just have a difference of opinion about what the meaning is. I mean, one of the studies in the phase 3 from the data that was available showed that there was a slowing of cognitive decline on the global measure, on cognitive measures. It was small, but there was a significant difference. The other study did not show that, so that's part of the controversy there. The earlier trial, which was smaller, showed some encouraging clinical results. And one thing that I'm influenced by, I had 17 patients in that early trial that were on the drug for more than 5 years. And this is data that was presented to the FDA, Biogen presented to the FDA. I don't know if it's in the public domain, but those that got the high dose for those 5 years had a slower cognitive decline. And I know, and families, it wasn't for every family and it wasn't for every patient. So we have to figure this out. Why does it work for somebody and not somebody else? And I think we can test for tau and other things to try to start to solve that question and predict who's likely to respond. As we talked before, the Aducanumab trial actually used a tau measure and only included people with a limited range of tau pathology in their amyloid antibody trial. But anyway, for 10 out of the 17, it was a relative stability over more than 3.5 years. And that you typically don't see that in Alzheimer's. And the families noticed it, I noticed it. It's the first time in scores of trials that I've noticed anything that might be a clinical benefit. So
and we should be extra clear to people who don't know as much as we do about this drug, especially you know much more than I do, but this is really a drug that's only been tested on early stage patients, right? So, it's not for people, and we're already getting emails and comments on our website at people asking, where do I get this drug? How can I get it? Does this mean I can get it? And, I think that has to be communicated very clearly that this is not, my mom is in a later stage of Alzheimer's. This is not a drug that has been tested in anyone in her stage. So, my question is,
that's really important. I haven't finished reading through the label, the package insert, but I think, and Lon, you can correct me, I think the approval is for Alzheimer's disease.
So maybe I could say just a couple of things. What you actually see, as Steve said earlier, we may disagree on some things. I'm not sure we disagree on very much at all. FDA did have the option of approving the drug and saying on the basis of cognitive improvement. They could have interpreted the studies, as Steve was describing, as showing evidence of cognitive improvement. They didn't do that. So the indication on the label, reading labels could be very complex, but the indication on the label is for the treatment of Alzheimer's disease. What you're supposed to do then, as an informed doctor, an expert label reader, is you're supposed to take that and go to the clinical studies section and note the inclusion criteria in the clinical studies section. That then informs you as a physician or as a prescriber what patients were tested and allows you to then make your decision. So the normal interpretation is it was approved for MCI and early AD, but there's a little flexibility there.
So
But
does that mean?
Deborah, I'm concerned about this because the label is so broad. I was hoping if there was an approval, there'd be a more narrow label that mirrored the trial, because the only evidence we have is from the trial. And so
a narrow label. This should be interpreted as a narrow label. But
well, I agree with you totally. And we're interpreting it. We're planning to offer this drug, and we're going to follow the clinical trial guidelines, and we're going to make our own label, because it's not, at least what I read so far, it's not provided. But I'm concerned if it goes more broadly. I don't know how other providers are going to interpret that. And there's really no evidence that it works for later stage disease, and it probably doesn't work for later stage disease because based on the biology, what we know about Alzheimer's, the amyloid process is pretty much peaked during this earlier stage. So
yeah, I mean, I've talked to people at Biogen that they were concerned. That was the biggest worry. If this drug was approved, that everyone would think that, wow, this is for everyone, right? And, it hasn't, maybe we need a lot more testing.
I'm really concerned about that.
Yeah.
I'm also concerned about, again, the little part I've read is that the safety guidance in the label doesn't mirror the trial. And I'm very experienced in monitoring for the fluid shifts. And we did it a certain way in the trial with a lot of backup world expertise. And now they've loosened it and we won't have that backup. So that's
wait, sorry, can you go into that a little bit more? What exactly do you mean by that?
They asked for an MRI, screening MRI 12 months, up to 12 months before. That's okay. At least we haven't seen it yet. We have a criteria. There can only be so many microbleeds on the MRI scan. It was up to 4. They don't have that in there. They say up to 10, no more than 10 later on or something, but that we never studied that. So at that population, that makes them at higher risk. We had safety MRI scans every 3 months. They're calling for a safety MRI before the 7th infusion, before the 7th month, and at the 12th month, only 2. And unless there's symptoms or something happens along the way, but you can't rely on that with this main side effect. It just makes me nervous in going to a broader population. They've loosened the criteria. I think if anything, they should help very firmly to that, at least starting out until we got more data.
Well, especially because I'm talking to 2 doctors who are experienced with this drug, right? And so you have that knowledge. I mean, it is a bit worrisome.
Again, in the forums that I have, I'm going to encourage people to follow the evidence that we have, especially for safety, and we want good clinical practice. And I can't see how to do that by making it more liberal in a much broader population with much less expertise.
I think I hate to predict the future because I'm really not good at it, but I think that what we'll also see is that Medicare, the Center for Medicare and Medicaid Services, will issue some considerable guidance about safety. They'll essentially be saying, we will reimburse to this amount in these particular patients who fulfill these criteria, and will also reimburse for the appropriate safety tests and for your safety visits if it's followed in a certain way. And that this is what we kind of depend on, that we can't depend on the FDA to give us all this detail when they approve the drug.
Right. The thing that I'm actually not very clear on is when we talked about the conditions for more data, what does it mean? Is that in the trial? The FDA has now approved Aducanumab, but says, they want more data. What exactly does that mean? Who's going to be included, or is it a continuation of the study that's going? Or does it mean more people to recruit? What does it mean?
I'd love to venture a guess. So there's an agreement between, if in fact the drug actually reaches the market, there will have already been an agreement, if there isn't right this moment, of what Biogen is obligated to do. The FDA has said, and Biogen agreed that they will do this kind of a further study to confirm clinical benefit. It could be, and Dr. Salloway may know, it could be a randomized placebo-controlled study. It could be an observational study. It could be something. We would want to know that. So that's a long way of saying, I'm not quite sure what they need to do.
Yeah.
But
I haven't seen the details on it. I haven't heard I agree with Lon. I haven't heard the details, Deborah, on it.
So are we at a point though, Dr. Salloway, where we can actually say, all right, let's try this on later stage Alzheimer's? Do we have enough data around that, or?
I think I answered that one very clearly, resoundingly. Absolutely not. We have no data, and what we have is from other drugs that didn't work. So, and it wasn't even close. So the answer is no. That would be. And also, I don't know if the FDA gave guidance about amyloid testing, but I think we definitely need amyloid testing to determine eligibility for this treatment. So
Okay.
for early stage, well, in my opinion, it's for early stage for those that are early Alzheimer's that are building up amyloid.
And Dr. Schneider, what about you? What will you tell your patients if they come in with early stage memory loss?
same thing. No, still, we don't know what we actually can do. We don't know the actual availability, the actual costs, the accessibility.
Right. Oh, absolutely.
I'm particularly concerned about whether people who are disadvantaged will be able, economically disadvantaged, will have access to this. So we'll know a bit more, but we see what the indication is on the label. Testing this in people who have more severe dementia, or for that matter, much more mild symptoms, those would require formal studies, and not. I wouldn't want to wing it in a clinic.
So to be really clear, because some people are even confused about defining the different stages of Alzheimer's. How would you say, at what point is early enough?
Deborah, I'm going to have to drop off. I apologize. Okay. Lon, good talking with you.
Okay, we're wrapping up anyway.
Okay.
Well, thanks so much, Dr. Salloway. Take care.
Bye.
All right, I'm just going to end. Dr. Schneider, if you just want to answer that one question, and then we'll exit.
Yeah, I forgot the question.
I was saying how early is when people are coming to you for memory loss, what is categorized as an earlier stage of Alzheimer's?
An earlier stage of Alzheimer's disease pathology is having memory impairment that we can observe, that we can measure. It could be a slight degree, but it's clearly memory impairment that does not reach the level, that is not associated also with impairments of activities of daily living, of function, of driving, of doing finances, doing checkbooks, of shopping, of doing ordinary activities of daily living. That would be early stage. The early stage could then move, and that's what we call mild cognitive impairment due to Alzheimer's disease. Early stage could then move into what we call, unfortunate term, mild dementia. And all we mean by the term dementia is not whatever it meant in the past, but that the person has some difficulties with activities of daily living.
Right.
That's the group that would be eligible by FDA indications by the FDA indication to receive this medication.
Okay, thank you so much, Dr. Lon Schneider. Thank you for joining us. And of course, we had Dr. Stephen Salloway, who had to rush off as live interviews go. But thank you so much for your time. I'm sure we're going to get more questions on the site. We may come back to you again, but thanks for, on such short notice, appearing on Being Patient. It's very helpful to our community.
Oh, well, thank you for the invitation.
Okay, and so if you missed any of that interview, we're going to post it on beingpatient.com. Send us, a lot of questions are going to come in. Send us your questions. If you have them, I think a lot of people need a little bit of time to digest this, what this FDA approval means, and if they or their loved one is a candidate for it. We have lots of coverage on beingpatient.com, including from people who are on, who were on the stage 3 clinical trial. So please sign up for our newsletters if you want to hear more about these live talks. We always let our audience know. Thanks very much for watching, and we'll see you soon.